Hi everyone, we're now going to move on and talk about a concept known as pH partitioning, and we'll finish up then with other processes that also govern drug transport. Now you might be looking at this word pH partitioning and wondering what the hell that is. Well, it's not as complex as you think. If you think about our bodies and the multiple compartments that exist, it's all about how the acidity or the alkalinity of two compartments separated by a cell membrane will determine whether, in our case here, drug molecules will get stuck in one compartment or will be able to be, absorbed into the other compartment. So we'll be able to cross cell membranes. I can also guarantee you that once you get your head around all of this, you're going to feel super duper special. All right, to begin with though, we do have to do a little bit of revision, okay, in terms of acids and bases and the pH scale. So remember, acids are compounds that when placed in an aqueous solution such as water will dissociate to release hydrogen ions. And bases then are also compounds that when they're placed into aqueous solution, they will also dissociate to release the hydroxyl anion. In terms of our subject here, we're going to talk about bases in terms of being able to bind or take up free hydrogen ions. Now, as you probably remember, the pH scale is a measure of, the acidity or alkalinity of a particular solution. You can see it here. It goes from 0 to 14, and it's a logarithmic scale. We have, 0 to 6, which is classified as acidic solutions. We have 7, which is neutral pH, and then we have 8 to 14, which indicates basic solutions or alkaline solutions. So what the pH scale is measuring is the amount of free hydrogen ions in a solution. I mentioned it's logarithmic, so for every change in the number here, there's a 10-fold difference in the number of free hydrogen ions. Solutions 6, 5, and sort of 4 tend to be, called weak acids, and similarly 8, 9, and 10, and 11 are weak bases. And the higher the number goes in the basic range, the stronger the base, and the lower the number goes down here, the stronger the acid. And taking here, for example, coffee has a pH of about 5, and that means, that it's 10 times less acidic than, say, orange juice there. And similarly, we have sodium hydroxide there, which is a pH of 13, and it is 10 times, or let's say 100 times more basic than soap. So looking at the dissociation of acids and bases, and starting with both a strong acid and a strong base example. Our strong acid is hydrochloric acid. Here we have it in its unionized form. When we put that into aqueous solution, it fully dissociates, right, to release, so it becomes fully ionized. It releases all of its hydrogen ions and all of its chloride ions, and the hydrogen ions there in the box just indicating, that it's an acid. So when it fully dissociates to release all of its hydrogen ions and chloride ions, that means there's none of it left in the unionized form. I've put this in here again. There's full ionization. It's, it's charged, so very water soluble. So it's not going to be easily absorbed, right? Because remember, we talked about things being lipid soluble are more easily, absorbed compared to things that are water soluble. Similarly with a strong base, which we have sodium hydroxide here, when we put that into aqueous solution, fully dissociates to release all of its sodium and hydroxyl anions, and that square there is just indicating that it's a base. So again, when this happens, you lose all of this unionized form because it's all been ionized. So again, full ionization of a strong base in an aqueous solution, it becomes water soluble, not lipid soluble, so it's not easily absorbed. So it can't freely, cross cell membranes. So for this, what I want you to remember is that strong acids and bases dissociate fully and become ionized at all pHs. On the other hand, weak acids and weak bases only partially dissociate. So here I've given you the example of aspirin, and aspirin is a weak acid. We have it here in its unionized form. When it's put into aqueous solution, it will partially dissociate, okay, to release some free hydrogen ions, okay? So there'll be some in the ionized form and there'll be some in the unionized form. And so it will be more readily absorbed than the strong acid, which was hydrochloric acid, because some of it is going to exist in the unionized, uncharged, lipid-soluble form, whereas some of it is going to exist in that, water-soluble, ionized form. And that's what this little bubble here is summarizing. Now, how much weak acids and weak bases dissociate depends upon the pH of the solution that they're in. Okay, let's go back to our aspirin. We have it here. And let's say we place that aspirin into an acidic media, right? What you're going to find when you put the aspirin into the acidic media is that this is not going to happen. Right? Because if you're in the acidic media, you already have hydrogen ions, so that acidic media is kind of saturated with hydrogen ions. And that saturation then is going to prevent this dissociation or this ionization, right? So what you find is that this aspirin in an acidic media will remain unionized. We know that unionized, no charge, it's going to be lipid soluble, or it's going to be in the lipophilic form, and that's going to mean that it's more of this aspirin in this case will be absorbed across, a cell membrane. Now, I am sure that some of you are already thinking, ooh, aspirin is a weak acid, and in my stomach I've got hydrochloric acid, and so what is that going to do to the absorption of that aspirin? But you're getting ahead of yourself, but it's great to be thinking that way, and we will get to it. I want you to concentrate here, though. Weak acids will ionize more readily in basic solutions, right? And that makes sense, right? Because acids are proton donors, bases are proton acceptors, so they're going to bind and take up that hydrogen. So if you've got more ionization of a weak acid in a basic solution, then it's going to become more ionized, more water soluble, less absorbed. And similarly, weak bases will ionize more readily in acidic solutions and therefore will be less easily absorbed as well because they're water soluble. Now, most drugs are actually weak acids or weak bases, and they are ionized at physiological pH. And the degree of ionization depends on the pH of the solution, as I've already mentioned. For example, stomach contains gastric acid, so hydrochloric acid, so very low pH. The urine is often slightly acidic, but this does depend on your diet. If you have a diet sort of rich in meats and cheeses and all of those lovely things in life, you might find that your urine is slightly acidic. If you have a diet, rich in dark leafy green vegetables, which are also very nice, by the way, but you don't have the cheese and the meat and all that, you might find that your urine is a little bit basic. But remember, our bodies are so clever and our kidneys are so clever that the pH of the urine can be altered to keep the pH of the blood plasma consistent. And arterial blood is slightly basic at 7.4. Okay, everyone, some of these slides are a little bit repetitive, but I want to say it in a couple of different ways so that everybody has a chance of, understanding this concept. So as I mentioned, many drugs are weak acids or weak bases and exist in ionized and unionized forms. Ionized molecules are water soluble. They have very low lipid solubility because they have that charge. Ionized molecules then are virtually unable to permeate membranes except where a specific transport mechanism exists, such as, a carrier protein or something like that. pH partition then and ion trapping. Ionization affects not only the rate by which drugs permeate membranes, but also the steady state distribution of drug molecules between two, say, aqueous compartments of differing pH, right? So if you take the stomach as a low pH and the plasma having a pH of about 7.4, what this basically means is that drugs will tend to accumulate in the compartment that they gain the charge. And this, of course, is what you're looking at here. Here we have an acidic drug. We've got it in its unionized form, and some of it has dissociated into that ionized form there. Of course, it's the unionized form that crosses this epithelial membrane here, so that phospholipid bilayer, and it enters the blood. And that then, some of that then will ionize again, and another sort of equilibrium then being established between the ionized and unionized form. Okay, so let's look at this here. We've got three different compartments. We've got gastric juice, so the stomach with the low pH of 3 there. We've got blood plasma, 7.4, and then we've got urine, and in this case, the pH of this urine is more basic than the plasma, so pH of 8. We've got two drugs here, aspirin, which is a weak acid with a pKa of 3.5. Don't get yourselves too bogged down with the term pKa, but it's just a number that sort of describes how acidic something is. And the lower the number, the stronger the acid, and the more willing it is to sort of donate its protons. We also have pethidine, which is a weak base, which has a pKa there of 8.6. So what we're looking at, let's say you take an aspirin for a headache or something, and you swallow it and it enters your stomach, where's the low pH? Remember, an acid in an acid is going to stay in its unionized lipid-soluble form, so you're going to tend to find that nearly all of that can be absorbed from the stomach. It's not going to accumulate in stomach, that which is indicated there by that very low number, and it's going to enter the blood plasma. Once in the blood plasma, the unionized form will ionize a little bit, which is what you're seeing here. So some of it will accumulate in the plasma, because remember, the ionized form is the water-soluble form that's less easily absorbed. Okay, but then you can see here that in urine, you're getting much greater accumulation of that weakly acidic drug, because remember, the pH here is even higher. So a weak acid in a base tends to ionize much more. So the bottom line of this is the acidic drug concentrated in the compartment with the high pH. This is known as ion trapping. So aspirin, being a weak acid, is found at a much higher concentration in urine compared to gastric juice, right? Now, if you look here at pethidine, it's kind of the opposite. It's a weakly basic drug. So a base in a base is going to stay more in its unionized lipid-soluble form. So it's going to be absorbed there from the urine back into the plasma. Again, some of that unionized drug then will ionize, so you get slight accumulation. But then you can see here that pethidine, being the weak base in the strong acid of the stomach, is going to be ionized a lot, right? So again, the point of that is the basic drug will be concentrated then in the compartment with the low pH, ion trapping, and pethidine then is a weak base that's found in gastric juice in much higher concentrations compared to the urine of that pH 8 there. And this is why pethidine is not normally, administered via tablet form, and it's usually given subcutaneously or intramuscularly, or can be given very slowly IV. So if we just summarize this again, a weak acid, for example, aspirin, in an acidic environment, they're mostly non-ionized, so lipid soluble, can be absorbed. Whereas a weak base, we had pethidine on the last slide here, and amphetamine, which is a weak base in the stomach, will be mostly ionized, therefore mostly water soluble, and therefore not easily absorbed from the stomach. Whereas the weak acid in the alkaline pH, mostly ionized, so water soluble, so more easily excreted in the filtrate. whereas a weak base in alkaline pH of the urine, mostly non-ionized, therefore lipid soluble, so not, can be reabsorbed back into the blood in that case. And if you're a visual learner, this is one I just drew out for you. Again, we've got our weak acid in unionized form in the stomach pH, so it can clearly cross. And then once it enters the plasma, some of that weak acid becomes ionized. So acidic drugs tend to ionize in alkaline media, and acidic drugs then tend to accumulate on the alkaline side. Whereas here the weak base in the stomach pH will be in the ionized form. So therefore the basic drugs will accumulate on the acidic side. So what you have to think about right now is that although ionization does affect absorption in the digestive tract, the relatively large surface area of the small intestines compared to the stomach, and the fact that food doesn't tend to hang around for long in the stomach, means that the small intestine remains the main site of absorption for drugs. However, if you think of some very trendy drugs that are being taken for weight loss at the minute, i.e. Ozempic, and we will learn more about that later on in the topic, one of the things that Ozempic does is it slows down gastric emptying. So thinking about that, then that's going to affect absorption of drugs. So we can talk about that more in the tutorial with if you're with me or with Andrew or Peter. So now looking in particular at how the alteration of the pH of urine can affect the excretion of weakly acidic or basic drugs. So if the urine is made more acidic, that will then inhibit the renal reabsorption of weak bases. Okay. However, it will allow the renal reabsorption of weak acids due to all this ionization, unionization that I've been talking about. So if you acidify the urine, then that will accelerate the elimination of weak bases and slow down the elimination of weak acids. On the other hand, if you were to make the urine more basic or alkaline, that will inhibit the renal reabsorption of weak acids, but allow reabsorption of weak bases, right? So it'll slow down the elimination of weak bases and accelerate the elimination of weak acids. Now, why am I talking about this at all? Well, currently, let's say you have a child who opens, the medicine cupboard and overdoses on aspirin. Well, currently, amines are used to alkalinize, that's a really hard word to say, the urine in the treatment of aspirin overdose. Because again, making the urine more alkaline will make the more of the aspirin ionize and therefore be removed from the body more quickly. This pH partitioning and ion trapping can also occur in the blood plasma, right? So if you increase the plasma pH, say by giving somebody more sodium bicarbonate, that will cause weakly acidic drugs to become ionized in plasma, right? And this helps then to extract weakly acidic drugs from the central nervous system into the plasma. On the other hand, decreasing the plasma pH will increase the concentration of weakly acidic drugs in the central nervous system, and therefore that can increase neurotoxicity. Again, it's through this whole, if you have a lower plasma pH, therefore you're going to have more of that weakly acidic drug being able to cross into the central nervous system and cause neurotoxicity. Okay, everybody, that's all I'm going to say on pH partitioning and ion trapping. We're going to move on now, and we're going to talk about other additional processes governing drug transport. And this includes binding of drugs to plasma proteins. So many drugs exist mainly in the bound form. And albumin is an important basic plasma protein that often binds to drugs, so acidic and neutral drugs. Now, binding to plasma proteins usually renders the drug inactive. Albumin is the main one, but there's also, the alpha, the beta, the gamma globulins as well. I'm going to give you an example here to explain it to you. Let's say you've taken a Nurofen, so ibuprofen, right? And about 90% of a dose of ibuprofen will bind to plasma binding protein. Once it's bound, it's in an inactive form. Okay, so that means 90% of it is inactive while it's bound and 10% of it is free. It's in the active form. What does that mean? It's free to cross membranes. It's free to interact with target cells, but it's also free for metabolism, and it's also free to be permanently excreted from the body. Okay, another example here is albumin binds to warfarin, right? And about 97% of a dose of warfarin is bound up to albumin. And that allows that albumin to, act sort of as a reservoir or a drug storage site. So the 3% that's unbound does the things I've just talked about, cross membranes, interact with targets, be excreted or metabolized and excreted. But then as that's occurring, then the albumin can release another 3% and another 3% and another 3%. And this sort of prolongs the time that a dose of warfarin is in the body. Now, we will talk much more about warfarin when we get to the cardiovascular system. But just remember when I spoke about, drugs that tend to be in the body for longer tend to be more problematic, tend to have more side effects, and tend to, maybe be toxic as well. Okay, now the binding itself depends upon the drug concentration, also the affinity for binding sites on the albumin here. So we do have drug interactions that occur if you have a couple of drugs that are competing for the same binding sites on the albumin. And one that does exist is between ibuprofen and warfarin. And when you're thinking about these two, types, or this type of drug interaction, because it involves drug transport or distribution, that's a phase of pharmacokinetics, right? So it's going to be a pharmacokinetic interaction. When you've got two drugs competing for a binding site, one's going to win, so it's going to bind as normal and follow its normal pharmacokinetics. The other one is not going to bind as normal, so you're going to have more of the drug in the active form. So you're going to have that drug then having a higher efficacy over a shorter amount of time, because remember that the active form is also available for metabolism and permanent excretion. The other thing that the binding depends upon is plasma protein concentration. The less the plasma protein concentration, then the higher the efficacy of the drug over a shorter period of time, as I've just explained. And a good example of that is, say, if somebody has liver disease or liver failure. So all of these, albumins and alpha beta gamma globulins are made in the liver. So if somebody has liver failure, they're not going to have enough of these plasma proteins, and therefore, those drugs won't be able to bind to the plasma protein, and therefore more in the active form over a shorter period of time. So when somebody does have liver failure or are in liver disease, dosing of drugs needs to be carefully considered. The last thing I'm going to talk about is partition into body fat and other tissue. So adipose tissue or fat tissue represents a large non-polar compartment. And this is important for a few drugs, not for most drugs. And that's because the fat to water partition coefficient is low for most drugs. So they don't tend to accumulate in fat tissue. Remember as well that there is very low blood flow in fat tissue. And I think, sort of explaining all of this with an example is the easiest way to do it. Morphine is a drug that has a very sort of low partition coefficient of a fat to water ratio of 0.4. What does that mean? It means that most of the drug is actually remaining in the blood plasma and not much of it is accumulating in fat tissue. While thiopental has a 10-to-1 ratio, so much higher. And for this, so thiopental, as it says there, will accumulate in body fat, and therefore it's not very good as an intravenous anesthetic. You also want to consider, fat tissue in terms of doses of drugs. So considering doses, in males versus females, where females have a higher degree or higher percentage of adipose tissue. Also with age, we tend to, gain more sort of fat content. But if you think about it as well, if somebody is going in for a surgery and they need to have an anesthetic, and if you, well, let's say two people are going in and one is very, very lean and one has a much higher fat content, if you gave these two people the same dose of thiopental, the thiopental would have a much greater effect in the very lean person, whereas not so much of an effect in the person with the higher fat content. So you'd have to increase the dose if you were going to use it in that case. Amiodarone is another drug. It's used to treat cardiac arrhythmias, and it tends to accumulate in the liver and to cause hepatitis, and also in the lungs to cause this interstitial lung fibrosis. And chloroquine is a drug that's used to treat malaria and also rheumatoid arthritis, and it can cause retinopathy in patients with rheumatoid arthritis.